Good day to everyone. Welcome to Learn Nursing 101. We are Group 1, Section 2-1, BSN2 students of Lorma Colleges. In today's video, we are going to discuss about a condition called ectopic pregnancy. But first, let me introduce our group. Our group we have yours truly, Abedania Marjerong B, Mr. Obasa Dranrem Anthony M, Miss Awingan Leon T, Miss Fuller Jermaine Albert P, Miss Mangaliman Aldea T, and Miss Ramirez Sara Bernadette S. And with that, let us proceed to our main discussion. An ectopic pregnancy is a condition in which implantation occurs outside the uterine cavity. The implantation may occur on the surface of the ovary or in the cervix. The most common site is in a fallopian tube. Of these fallopian tube sites, approximately 80% occur in the ampular portion, 12% occur in the isthmus, and 8% are interstitial or fimbrial. But ectopic pregnancy can also occur in the ovaries, cervix, or even the abdomen. Moving on to the signs and symptoms. The clinical manifestations of ectopic pregnancy include amenorrhea or absence of menstruation, sharp knife stabbing pain in the lower abdominal quadrants, scant vaginal spotting, shock, meaning there are these following symptoms like rapid threading pulse, rapid respiratory rate, and decreased blood pressure. Leukocytosis, which is a high number of white blood cells in our blood, no gestational sac, rigid abdomen, umbilicus that develops a bluish tinge or the colon sign, extensive or dull vaginal and abdominal pain, cervical motion tenderness, and shoulder pain due to the accumulation of blood in the peritoneal area or the diaphragm. All of these clinical manifestations will be further discussed in the assessment part. Next, let us learn about its different risk factors. Risk factors include obstruction due to the adhesion in the fallopian tube from previous infection, congenital malformations, scar from the tubal surgery, uterine tumor, smoking, IUD, history of ectopic pregnancy, and oral contraceptives.
As we all know, an ectopic pregnancy can cause your fallopian tube to burst open. So without treatment, the ruptured tube can lead to life-threatening bleeding. So we have here the 11 assessment for ectopic pregnancy. So first, amenorrhea, or known as absence of menstrual period. So this is included as a first symptom for ectopic pregnancy. And then next, a sharp knife stabbing pain in the lower abdominal quadrant. So it is a short pain only. And then next, scant vaginal spotting. Remember that vaginal bleeding in ectopic pregnancy is the result of decidual breakdown in the uterine cavity due to suboptimal HCG levels. And then next, a shock such as decrease of blood pressure, rapid thready pulse, or we need to take note that all vital signs will be elevated. There is also increased number of WBC or white blood cells from laboratory result or termed as leukocytosis. There is also no gestational sac since the client have amenorrhea. And then next, there is a rigid abdomen. Since there is bleeding, the result is the abdomen will be rigid. There is also umbilicus develop a bluish thing or what we call colon signs. So this is a diagnostic sign where ruptured extrauterine pregnancy exists. And there are also extensive or dull vaginal and abdominal pain. And also, there is movement of the cervix and pelvis exam causes excruciating pain or a cervical motion tenderness. There is also pelvic pain as well as surgical pain when the doctor done to do the internal examination. And lastly, there is a shoulder pain or accumulated blood in the peritoneal area, so it tends to irritate the phrenic nerve. So that would be all for the assessment of ectopic pregnancy.
the diagnostic findings of ectopic pregnancy. So, diagnosis, a pelvic exam can help your doctor identify areas of pain, tenderness, or a mass in a fallopian tube or ovary. However, your doctor can diagnose an ectopic pregnancy by examining you. You'll need blood test and an ultrasound. So, in pregnancy test, your doctor will order a human chorionic gonadotropin or HCG blood test to confirm that you're pregnant. Levels of his hormone increase during pregnancy. This blood test may be repeated every few days until ultrasound testing can confirm or rule out an ectopic pregnancy, usually about 5 to 6 weeks after conception. So next is ultrasound, transvaginal ultrasound. A transvaginal ultrasound allows your doctor to see the exact location of your pregnancy. For this test, a wand-like device is placed into your vagina. It uses sound waves to create images of your uterus, ovaries, and fallopian tubes and sends the picture to a nearby monitor. Next is abdominal ultrasound, in which an ultrasound wand is moved over your belly, may be used to confirm your pregnancy or evaluate for internal bleeding. And lastly, other blood tests. A complete blood count will be done to check for anemia or any signs of blood loss. If you're diagnosed with an ectopic pregnancy, your doctor may also order tests to check your blood type in case you need a transfusion.
And now we are on the medical management of ectopic pregnancy, and we have to tackle two categories in here, which is the unruptured and ruptured ectopic pregnancy. First is the unruptured ectopic pregnancy. It's the hysterosalpingogram or ultrasonography. The hysterosalpingogram is done to check for black fallopian tube. This test may be done to look for the cause of infertility, while the ultrasonography is the diagnostic imaging study of choice for ectopic pregnancy. After the unruptured ectopic pregnancy, there is also the ruptured ectopic pregnancy. First is the blood sample will be drawn immediately, especially on getting the HCG level. Usually, during pregnancy, hormone levels increase 40 to 100% every 48 hours. But in ectopic pregnancy, it tends to be lower overall. But still, you may need to test HCG levels over a few days for definite results. The second one is blood transfusion. The use of salvage autologous blood transfusion for treating massive hemorrhage occurring during ectopic pregnancy is a safe and feasible method for rescuing patients with such condition because it can rapidly replenish the patient's blood volume and save blood resources without causing post-operative hemodynamic, blood routine, and electrolyte abnormalities.
Pharmacologic therapy. The therapy of an ectopic pregnancy depends on whether the woman is symptomatic or asymptomatic, or whether the ectopic is ruptured or unruptured. Administration of methotrexate. It is a folic acid antagonist type of chemotherapeutic agent. However, it essentially works by inhibiting rapidly dividing cells, which makes sense given that the fertilized egg is made up of rapidly dividing cells. The ectopic pregnancy can be stopped by taking this medication, and thus the occurrence can be stopped. Administration of mifepristone, an abortifacient that causes sloughing of the tubal implantation site. Both of these therapies would leave the tube intact and no surgical scarring. Surgical treatment of an ectopic pregnancy is usually an emergency because the patient is unstable. Salpingostomy and salpingectomy are two laparoscopic surgeries used to treat some ectopic pregnancies. In salpingostomy, the ectopic is removed and the tube left to heal on its own. While the salpingectomy, the ectopic pregnancy and the tube are both removed, which the procedure of a woman would have depend on the amount of bleeding or damage and whether the tube has ruptured. Also, a factor is whether the other fallopian tube is normal or show signs of prior damage.
Lastly, we have the nursing management for ectopic pregnancy. So first, we're going to ensure that appropriate physical needs are addressed and monitor for complications. We're going to assess the vital signs, bleeding, and pain. Assessing the vital signs to establish baseline data and determine if the patient is under shock. Monitoring for presence and amount of vaginal bleeding to further assess the present situation if it is indicating hemorrhage. And monitoring for increased pain and abdominal distension and rigidity, since an increase may indicate rupture and possible intra-abdominal hemorrhage. So we should also remember that there is going to be risk of deficient fluid volume related to blood loss secondary to ectopic pregnancy. So we're going to start input and output monitoring to monitor circulatory blood volume to ensure that the patient has adequate oral hydration or if there is a need to commence IV hydration therapy. Second, we're going to provide the client and family teaching to relieve anxiety. So we're going to explain the condition and expected outcome and also to describe self-care measures which depend on the treatment that the patient is currently taking. Third, there is also going to be powerlessness related to early loss of pregnancy secondary to ectopic pregnancy. And the nursing management here is to address emotional and psychosocial needs by encouraging grief expression by offering privacy, eliminating time constraints, and enabling support individuals of choice to visit. These interventions support the patient and the family in expressing their grief and starting the process of resolving it. Grief is a personal experience and people respond to it in different ways. Support could be given effect by acknowledging the patient's and family's emotions and encouraging expressions. So, a woman who has had an ectopic pregnancy not only has grief stages to work through, but also may have problems of diminishing self-image and a sense of powerlessness if surgery included a removal of the fallopian tube. So, we're going to need to encourage her to verbalize her concerns about this and her possible reduced potential for future childbearing.
This is our references. Thank you for watching and happy nursing.